Tamil Nadu chapter of IPS Scientific Committee. I welcome you all for this child psychiatry webinar series. At the outset, we would like to thank our President Sir and all the EC members for allowing us to conduct this webinar series on a regular basis. And I'm sure like it will be a useful program for many of us because like as we actually look into the child psychiatry aspects, many practitioners find it very difficult to deal with the clinical aspects of developmental disorders when they present to us in practice. Particularly, we have a lot of information we have heard as far as autism in childhood is concerned. But how do we actually identify if somebody turns up in our clinic when they become an adolescent and probably we would have missed out or the subtle autism signs in childhood or atypical PDD presentations. So I think our speaker for today will actually throw us light based on his clinical experience also and would be actually taking us through the journey of how to decode autism in adolescence and what are the clinical challenges. Over to Dr. Shainika to introduce the speaker for the day.
Good evening, everyone. It's my pleasure and privilege to welcome Dr. Venkateswaran. He's a senior and he has completed his fellowship in child and adolescent psychiatry from Christian Medical College, Vellore. He has his key areas of interest in neurodevelopmental disorders, predominantly in autism spectrum disorders. He has authored many publications. He has authored chapters in differential diagnosis in pediatrics. He has authored review articles in IJPP and in many peer-reviewed journals. Over to you, Dr. Venkateswaran, sir. It's a pleasure to have you here with us.
So, thank you, Shainika. So, I like to thank IPS Raman sir and Shainika for this very good opportunity. So, I'm extremely honored to present in this forum with the esteemed psychiatrists in the forum. So, today topic is decoding autism in adolescence. Okay, what are the clinical challenges we face? Yeah. So this is like the nutshell of autism in adolescence. It is not that like we all know the autism is a neurodevelopmental disorder which starts at the very early stage of development. Okay, sometimes we see symptoms as early as 3 to 6 months where the social smile is absent. But why some cases are discovered in adolescence? Is it onset in adolescence? No, definitely no. The onset is there, but it emerges in the adolescence where the social demand increases. So till then, like somehow the child and the parent is managing, and in the adolescence, when the body changes, when the hormone changes, when the load increases, academic load increases, when the social pressure increases, that is when you actually start seeing symptoms of autism spectrum disorder complicating other issues in adolescence. So
Yeah.
so the like that is why the many autism cases are discovered in adolescent age for the first time. Okay, so contents, like we will answer these questions: why, what, where, and how. Why the autism is diagnosed in adolescence, and what are the symptoms that we commonly see in adolescents with autism spectrum disorder. So where do we look for? Okay, so in which population generally we look for symptoms of autism, especially in adolescent age. Okay, and how are we going to assess? Okay, so these are the questions we are going to see, and we will answer the same slide in the end of the seminar. So with a brief introduction, ASD is estimated to occur 1 in 36. It's a huge burden. Nowadays the burden is increasing day by day, and it is defined as one second. Sorry. Sorry. Yeah. So defined as deficits in social communication and restrictive repetitive behaviors, we all know. And the prior studies have shown that rates of persistent of ASD for children diagnosed at younger age ranges from 68% to 100%, almost more than 70%. So then why we are seeing ASD for the first time in the adolescent? So the answer is why. Okay, so This is a recent study. Okay, this is published in JAMA Pediatrics, so one of the reputed journal. Persistent of autism spectrum disorder from early childhood through the school age. So this particular study is very interesting. So they have done a cohort study, okay, with a very good methodology. So 213 children has been followed up. They were diagnosed as ASD in 12 to 36 months with a very good method. It is not that like somebody has diagnosed randomly. So the multidisciplinary team has diagnosed as ASD with clear criteria at 12 to 36 months, and they have followed up the children for 5 to 7 years of age. So in that, the findings are interesting. 37% have non-persistent symptoms. Okay, nearly 40% of them are losing diagnosis. Okay, so this is a very good, very optimistic finding. Okay, so it is not that like they are completely coming out of ASD. They no longer meet the DSM-5 or ICD-11 criteria for ASD, which itself is good. Like they almost mimic neurotypical children of that age. Okay, so these findings in this study suggest ASD diagnosis in younger children less than 3 years may not persistent, and child specific factors may be associated with this. So the factors which this particular article has given: higher baseline adaptive functions as measured by VSMS or VAPS, and female gender is likely to have non-persistent symptoms. And another interesting finding in the study is irrespective of intensity of the early intervention. Okay, so the early intervention does not predict whether the autism symptoms are persistent or not. So irrespective of early intervention, some children, they don't retain the diagnosis of ASD by school age, that is up to 7 years. So this could be one of the reason. Natural trajectory of the developmental problem per se explain to us that why we see some children or getting diagnosed in adolescent age. They might have some symptoms in the beginning, and like they no longer meet that criteria. They go through school years successfully, and suddenly when the demand increases, they may go on to have difficulty, and in turn they get diagnosed. And another reason, the next reason for why late diagnosis in autism. Okay, this is a systematic review. If you see the generally the bimodal cutoffs for the diagnosis. Okay, sometimes it is diagnosis in the toddler age and preschool age, and some times it is diagnosed in the late adolescent and early adulthood age. So this bimodal distribution of cutoff, critical period of intervention. So why like these? It means if some major many of the children are diagnosed in the adolescent, it means they are not diagnosed in the early age. So the reason could be these. If you see this evidence, 25% of the children with ASD symptoms remain undiagnosed by age. 25% is a huge number. Okay, it means they are not at all diagnosed in the childhood. Okay, and 21% receive delayed diagnosis after initial assessment of no ASD. These are evaluated. This 21% are evaluated, and it was said to be no diagnosis, but later on go on to diagnose as ASD. And if you see the adult study, majority of the adult diagnosed as ASD have no childhood records of getting diagnosed as ASD. And females diagnosed significantly later than males with comparable symptom severity. So it's camouflaging occurs. Okay. So the evidence, the previous evidence as well as these evidence shows many ASD children are getting missed in the early age group. Okay. So they show some symptoms. Sometimes the parent will not take them to evaluation. Sometimes even when they are evaluated, it is not diagnosed. So these lead to these children getting diagnosed in the adolescent age. So the factors involved in the misdiagnosis: gender bias. Naturally, female children, the diagnosis is missed in the early age. Higher cognitive ability. If there is no language delay and their high IQ, they somehow compensate for their social communication difficulty with their intelligence, and the diagnosis get missed. And later on, when the social demand increases, they get diagnosed later. Diagnostic overshadowing. Sometimes it is diagnosed as ADHD or unspecified development delay. All this diagnostic overshadowing happens when they actually get evaluated in the early age. And last but not least, significant factor: parental and clinician bias. Many times we come across in our routine practice like when some parents, they are too anxious and like too, like we cannot communicate, even though it is very clear ASD, even sometimes severe ASD, we cannot communicate in one or two visits to them that the child is having ASD. They are very anxious. They will almost push you to tell, no, it is not ASD. Okay. And you will be really concerned about their mental health, like when you break the diagnosis. So it requires multiple sessions. Many a times when you take time as a clinician, okay, the parent is not in the steady state of mind, it is a clear cut ASD, we have to communicate. Many a time, like when you want to take on a few sessions to convey, they will lose follow. So these children will not get diagnosed, especially when the symptom severity is mild and it is very clear. Okay. And clinician bias, sometimes many clinician has that stigma of conveying, breaking the bad news, leading to them not getting diagnosed. So these are the factors involved in misdiagnosis. So misdiagnosis and natural trajectory of the illness both lead to the children not getting diagnosed till adolescent age and later on getting diagnosed. So diagnosis in teen. So these are the reasons why it is not getting diagnosed early. Okay. So then what? Okay, what are the symptoms that you will see in teen when they have ASD? So signs of autism sometimes become clearer and more noticeable when the children in their preteens or teens. This might be because of the new primary or secondary school environment involves more demanding schoolwork, more responsibility, and more complex social relationship, as I was mentioning. And these can be challenging for autistic preteens and teenagers, and the signs of autism becomes more obvious as a result. So it is not that they are having autism at adolescent age, like because of the challenges, it is seen. So, like in children, again, we divide into two, like social communication difficulty and rigid repetitive behavior. The social communication difficulty signs in teens and pre-teenagers. Verbal difficulty in verbal communication, how it presents in teenagers, not take turns during conversation. For example, they may not ask questions about other person interest. When two people talk, like they will talk like a monologue, they will not talk about others ideas. And sometimes they find it hard to answer, like for example, say, tell about yourself, they may not be very fluent. Okay, so they have deficits in verbal communication in this way. And they talk a lot about their interest or special interest, but find it difficult to talk about other range of topics. So they will be too narrow. Okay, so they cannot get along with other peers because they keep talking about their own interest all the time. Take things literally. Okay, they will be confused with the expression like pull up your socks, and they will actually do it in a literal sense. So that abstract thinking will not be there. Okay, so these are the deficits in verbal communication you will see in teenagers with autism spectrum disorder. Differences in the voice or way of speaking, sometimes it may be very loud, uh, or odd accent, or like voices might not vary, like too less inflections. So all these things are possible. Sometimes it is over animated way of speaking, or very odd tone, or sometimes there is no variation in tone. They can have very good vocabularies, because if you see, like in adolescence, our topic, it is mainly on high functioning and mild ASD, because if it is severe ASD with intellectual disability, they won't get diagnosed in the adolescent age. They will get diagnosed very early, and like the autism diagnosis does not pose a challenge in the adolescent age. So we are talking about very mild ASD and high functioning individuals, at least IQ more than 70. So naturally they are going to have very good vocabularies and formal language, but these difficulties are noticed in adolescent age. They will not have like a problem in language per se, but these finer aspect of language, they will have problems. Non-verbal communication, not notice or understand non-verbal clues to other people feeling. For example, they might not be able to tell when someone is teasing them or using sarcasm. So in this way they get bullied a lot. Even though they are bullied, like they will not recognize that they are getting bullied. Less eye contact, this is one symptom which is persistent from the childhood. Less eye contact with other people, and they find it very difficult to interact face to face. not show much emotion on their face, or not able to read others' facial expressions. Okay, they might not be able to understand when they talk, like they will not be able to understand whether somebody is bored or they are listening to them. They just go on talking. So seminars are the exception, but they just go on talking in the one-on-one interpersonal conversation. Their gestures, coordination between their gestures will be less. Okay, so these are the non-verbal deficits that is seen in adolescent age. Overall, the non-verbal skills looks clumsy. Okay, the clumsy and less coordinated. Okay, next is developing relationship, prefer to spend time alone. This is easier to recognize, not much friends. They prefer to spend on their own, okay, than with their peers. Or they might find it with the older adults or much younger children, where they are easy to, the older adults will adjust to them, and the younger adults again, they will listen whatever the children with autism, teen with autism say. So it is, they will have mates either older than them or younger than them. Okay, want other children or adolescents to play by their rules and get upset if their rules aren't followed. They are too rigid in relationship, leading to loss of friendship. Difficulty in understanding unspoken rules, like they should not touch unnecessarily, they should maintain that distance, safe distance. Okay, they cannot scroll others phone without permission. So unspoken rules will not be followed. Okay, in this way the social relationship will look clumsy, and generally other children will tend to avoid. Many time what happens, they crave for friendship, they want friends, they want more and more friends, but they will be avoided because of their clumsiness in their relationship. Okay, and leading to they have difficulty in making friends and might have few or no friends. Okay, and have difficulty in adjusting their behavior to the different social situation. They'll be say like same in almost all the social environment. Okay, the social awareness will be less, adapting to the situation will be less. And if you see previously, like unspoken social rules, they will not be able to follow. Sometimes they'll be too scripted. Okay, rely on social script to interact with others. Okay, they might behave in the same way with the teacher as well as the peer. Okay, so they'll be too rule bound. Okay, they rely on social scripts and not able to modify it, so it will look very odd and they will get ultimately bullied. Okay, and find it difficult to handle unexpected or challenging social situations. Overall, problem in verbal communication, problem in non-verbal communication, problem in relationships. So all these things are seen in adolescence, and these will look like soft signs. Many times parents will not be able to recognize these symptoms, because like many, they somehow get adjusted to them, and for them it looks normal. Okay, very difficult to convince the parents that these are all actually a social difficulty, and what the adolescence is actually going through in their day-to-day life in school and other places. Sometimes parents say, what is wrong with this? Like, he is normal socially, in fact he is very social. How can you say like he is having social skills deficit? But for them, they will not realize. But the adolescents, unfortunately, they will get bullied left and right, and when we try to explain, it results in lots of negative taste sometimes. So this is one criteria. Next is behavior signs and sensory issues of autism. It is almost same like childhood. That includes repetitive behavior and interests, very intense special and special or intense or special interest. Like for example, they might collect or memorize football statistics, but may not be interested in the game. Okay, so have behavior that seems to be repetitive and compulsive, like need to close all the doors in the house, like they have to follow that, they cannot accept otherwise. And particularly attached to certain objects, like carry toy which is not developmentally appropriate in that teenage. Okay, these repetitive behavior, unlike childhood autism diagnosis, where like it will look very abnormal, these repetitive behavior on the face value sometimes looks normal, but people who stay with them, they find it extremely repetitive, and they are clinging on to it. That is when like it becomes problematic. Okay, the over representation of a normal behavior of the adolescent sometimes, but they will hold it to a very high intensity, and they will upset by change in routines, leading to significant behavior problem. And this motor and verbal stereotypes, usually it will disappear as they age, and especially in high functioning autism and very mild symptoms. But sometimes symptoms may persist, but they will be able to mask in social contact. They may not do it in the clinical room, they will not do it in school, but they may do it at home. From history we can find if there are still motor and verbal stereotypes are persistent. Okay. And sensory issues, either sensitive to environment, or sometimes they may seek sensory stimulation, less response to plain, same like how children do. Okay. But again, like stereotypes, the sensory symptoms usually improve over age, but they will be able to mask also. Okay, the seeking they will not do publicly, they may do it in a private place. The parent will be able to give a good history of these sensory issues, very difficult for us to observe in the day-to-day clinics. So the sensory issues are also common in adolescents, but they'll be able to mask it. So these are the symptoms. So these are the symptoms that we may see in adolescence. It is very soft, very subtle, and sometimes the clinician have to really convince the parents about the presence of symptoms, and it may vary from one doctor to another, adding to the complexity, because it is very mild and very subtle, but the dysfunction is out of proportional. Because of these symptoms, the emotional distress and dysfunction the adolescent go through, it's very intense. It's much intense than what the child can go through. Okay. So it is answer to the question what, then where. Okay. Are we going to get only adolescents with social difficulty for the assessment of autism? No. Okay, nobody is going to bring, like, very maybe less 10% they are going to bring the socially is weak and probably require evaluation. Okay, so but most of the time where we are going to find these adolescent with autism, it's mainly clinical population who is coming for other psychiatric illness. Okay. If you see, 70% of the individual with ASD have at least one co-occurring psychiatric illness, and we all know many of these psychiatric illness have this onset or at least prodrome in the adolescent age. So most of these individuals with autism, they present to the clinical setting with some psychiatric disorder, where they will go on to get diagnosed as autism as the process of this. So depression, 23% has clinical depression. It is fourfold more than general population. Okay. Autistic adolescent with depression face elevated, this adding to the complexity, face elevated risk of suicidal ideations and attempts compared to general population, because already they have very intense emotional response, and they are at a very higher risk of suicide. If you miss probably ASD along with depression, probably there's a higher chance we may end up losing the patient. And it will also causes diagnostic confusion, diagnostic overshadowing in either way. Sometimes if we can say the depression is part of ASD, like social deficits of ASD, sometimes the social deficit can be taken as part of depression, so diagnostic overshadowing is possible. It will mostly present as irritability, aggression, mood lability, and sometimes they may misdiagnose as bipolar disorder. Okay, some ASD children, the depression itself can present as externalizing behavior, and this changes in this repetitive behavior, sometimes it reduces or sometimes it increases. High somatic manifestation, non-specific aches and pains, or tiredness, vague tiredness may be the sole manifestation of depression in children with the autism spectrum disorder. And alexithymia is also very common. They will find when you ask for low mood, they will say like, I don't have low mood. But like if you ask the question like, do you feel any emotions, so sometimes they may say, I don't feel any emotions. So this alexithymia is also one of the presentation of depression in adolescents with autism spectrum disorder. So this will add to the diagnostic confusion, resulting in significant morbidity. Anxiety disorder, that is also like up to 84% of ASD have co-occurring anxiety, and up to 40% can have more than one anxiety disorder, and sometimes the presentation may be atypical, as I mentioned in terms of depression. OCD. Again, this will confuse the diagnosis. Studies report ASD prevalence among OCD youth ranging from up to 25%, 9.5% to 25%. See, if you see, it's very wide data, because sometimes the criteria used for ASD and OCD, it overlaps. The pool prevalence is 11.6%, representing six-fold increase compared to 2% prevalence of OCD in general population. So, in ASD population, it can increase up to 11.5%, that is 5 to 6 fold more. Okay. And intense interest and preoccupation in ASD are typically enjoyed rather than experiences intrusive as an OCD. So how to differentiate? There won't be any ego dystonicity. Okay, they will like enjoy this intense interest and preoccupation, unlike in OCD, which is basically very distressed. Okay, so in OCD, the prevalence of ASD is high, OCD population, and ASD population, the prevalence of OCD is more, and both can cause diagnostic confusion. And other next three things, functional neurological disorder, again, an adult study, if you see, in adults with functional neurological disorder, that is previous dissociative disorder, the prevalence of ASD is very high. Okay, and 69% later on get properly diagnosed as ASD by this adult autism assessment. Okay. If you see children data, 10% of children with functional seizures have ASD. So in this population, like there is very high prevalence of ASD. The children presenting to OPD with functional neurological disorder, if you carefully look for ASD symptoms, social communication deficits or repetitive behavior, where that may be the source of functional neurological disorder, where like these children find it very difficult to interact in the school. Sometimes they will be too rigid and where they will be challenged. So it results in significant distress that can ultimately lead to these functional symptoms. So the prevalence of ASD in the dissociative disorder population or functional neurological disorder population is very high. The next two, eating disorder. Many a times, like the overvalued idea that is very commonly seen in children with ASD, like they go on to develop eating disorder. Okay, 16% ASD prevalence in eating disorder cohort, and AFRID, like again 12 to 16%. It's very high, 10 to 15 times higher rates of eating disorder in population compared to general population. In ASD, it's 10 to 15 times higher. Higher rates of ASD in eating disorder population than general population. Gender dysphoria, again another condition where like you see very high incidence of ASD. The children or adolescent diagnosed as gender dysphoria, they have high prevalence of ASD. So these are the places where we look for the adolescents with presenting with these symptoms. If we carefully look for symptoms of autism spectrum disorder, which is not diagnosed previously, but we may go on to develop diagnose in the later age. Here the treatment implication is very important, because like sometimes when we don't recognize the presence of ASD in this population, in this mental health population, we may end up over treating it, thinking that is also part of these group of disorders, and we may not fine tune the therapy accordingly. Okay, sometimes the ASD children need some modification even in CBT, the way we approach more visual inputs, and acknowledging their some of the deficits, not trying to change some of the deficits. So these modifications are important in ASD children with these mental health issues. But if we don't recognize ASD in these, if you see this data, all this research evidence, the very high prevalence of ASD in these group of mental health issues. And psychosis, here it is other way around. It is not like ASD is highly prevalent in psychosis or other way, but here it will add a lot of diagnostic confusion. Okay, cognitive rigidity in ASD may be similar to delusion in psychosis. One of the most significant clinically significant diagnostic pitfalls involves misinterpretation of cognitive rigidity, characteristic of ASD, as a psychotic delusions. Sometimes this cognitive rigidity can be diagnosed as delusions, leading to inappropriate treatment or intervention and delayed recognition of underlying neurodevelopment condition, leading to significant poor outcome. Okay, many times adolescents come with ASD, come with lots of cognitive rigidities, can be misdiagnosed as delusions. Another common diagnostic error, interpreting presence of imaginary friends or companions in adolescents with ASD as a evidence of hallucinations. Many times they because of the social craving and they are ignored socially, they may have they will present as lots of imaginary companion. They am talking with my imaginary friend. My imaginary friend is telling to do me to do this, do that. It is misinterpreted as hallucinations, and they may end up getting treated as psychosis. So sometimes the ASD adolescents when they have problems, it is commonly misdiagnosed as psychosis or schizophrenia, and they are pumped with antipsychotics one after another. Sometimes, because it is not improving, they may end up with clozapine also, leading to lots of poor outcome. So here we have to be careful when we diagnose early psychosis with delusions and hallucination. We have to be like very open. Are we missing developmental disorder? Are we missing any symptoms of spectrum? Is it manifestation of ASD? Okay, is it like a cognitive rigidity? Is it like imaginary friendship which is misdiagnosed as hallucination? So we have to be doubly sure unless it is a classical psychotic presentation, especially when you make a diagnosis in adolescence. And it is not the only mental health disorder. Sometimes the deficits, okay, this cognitive deficits that is usually part of any developmental disorder can cause problem in adolescent. They will come for that. Okay, they come for executive function deficit, like a basically executive function is cognitive process that is important for self-regulation and goal-directed behavior. Okay, it is important for us to function by ourselves in a very smooth way. So essential for managing day-to-day activities and adapting to the challenging demands. So executive functions commonly includes planning, organization, working memory, cognitive flexibility, and inhibition of unwanted responses. So the executive functions are important for social interaction and academic success. When like the executive function deficits, which are part of any developmental disorder, sometimes these are soft skills. Many a time we have seen it's only executive functions. There is no illness diagnosed. Later on they may develop some or other mental health issues, but we have seen like adolescents coming with only these deficits. They are not self motivated, they are not organized, their cognitive flexibility is very poor, their inhibition to cut off unwanted impulse are very poor. So these deficits alone can cause dysfunction. Okay, so these are the research score, like the difficulty in this planning, cognitive flexibility, working memory, and inhibition. So clinical implications and intervention, executive functions increases behavior challenges. Okay, when they are not doing anything, they are not functioning, the parent keep nagging, the parent keep pushing, that leads to increase in behavior problem. In school setting, it results in more pronounced difficulties, leading to academic difficulty and peer interaction difficulty. Female adolescents may show greater executive function impairments in academic contexts. And sometimes early targeted interventions and context specific strategies can improve these executive functions. So, this the children, adolescents with executive function, there is a very higher incidence of ASD. So, we have to look for ASD. The next slide, it is a continuum. So, the executive function deficits are common in this combination. The children with ASD that is missed, and they also have comorbid ADHD. If you see this research, up to 70% of the individuals with ASD can have ADHD symptoms. Okay, so this ASD with ADHD, when both are missed in the early age and not treated properly, they will develop significant executive function deficits in adolescent age, leading to severe behavior problem. So greater daily impairment than single diagnosis. So it results in lower cognitive functioning and more severe social deficits compared to either diagnosis alone. Okay, when these individuals go through high stress because they are not functioning, when they have significant executive functions deficit because of these two developmental conditions, they are not functioning properly. So they will be coming as lethargic, not functioning at all. They have to be pushed, and when they are pushed too much, they retaliate. So it results in significant stress, and it makes them naturally high risk for other psychiatric morbidity over the years. Just imagine, over 4 to 5 years they have this executive dysfunction and they undergo lots of stress. Because of that, they are not functioning properly, their self-confidence is low, naturally for a whole lot of psychiatric morbidity. So this is one combination which we have to keep in mind when an adolescent presents with poor executive functions. In this cohort, we may not be able to diagnose any psychiatric syndrome. Like they will not qualify for depression. If you do depression rating, they will not qualify for anxiety. They will not have psychosis. But it's only executive functions alone where the ASD and ADHD are highly common in this cohort. Internet gaming disorder. This is now it is causing mayhem. Like to 2024 clinical study, if you see, 45% of ASD groups scored above cutoff for IGD in this rating scale compared to 9.5% in neurotypical controls. Okay, so see, just imagine the difference: 9.5% in neurotypical population compared to 45% in ASD. Okay, same study reported that ASD patient with IGD has more severe attention problem. So again, it is again a continuum. ASD with ADHD with severe executive functions, what they will do, they cannot cut off the impulse control will be poor. They cannot cut off immediate reinforcement for the long term gratification. So they will end up more and more. They will end up with more and more tasks that gives them lots of immediate reinforcement. This is one thing, like it is like a opening wine shop in our everyone's home. Okay, internet gaming disorder. So they will become completely addicted into it. A systematic review found autistic children, adults, and adolescent across age with autism, they are greater risk of problematic internet use up to 12 to 17 hours per week, which is much higher than the recommended usage hours. So they will go on to develop these internet gaming disorder. Next, what happens? So ASD missed, ADHD missed, severe executive functions. So they are prone for addiction. They develop addiction. Next stop, emotional dysregulation. So parents keep nagging. Parents keep setting limits. Over the years, these kids are highly pampered. Like they because they will act like a model child in their very early childhood. So these kids are highly pampered. Suddenly in adolescence, they will become like a completely a different person. So poor emotional regulation. 20 to 50% of ASD youth exhibit severe emotional dysregulation, 2 to 4 times more than neurotypical peers. Very high reactivity to negative stimuli. They cannot take no. Okay, it results in severe aggression and self-injurious behavior. Untreated emotional dysregulation predicts very poor outcome. Sometimes these individuals are diagnosed as personality disorders. If you carefully look into the developmental history, they might have one or two of these developmental condition, which over the time progress to significant emotional dysregulation. Like I told, for executive function, sometimes you may not be able to diagnose as one of the psychiatric symptom. You may not be able to diagnose as depression. You may not be able to diagnose as bipolar, because the criteria they won't satisfy that criteria. In future they may go on to develop some or other psychiatric syndrome, but at that point, when you commonly see in the adolescent and early adulthood, they may just have an emotional dysregulation that itself causes significant dysfunction. We need not diagnose as like any psychiatric syndrome for treatment. Sometimes these deficits like executive function deficit or emotional dysregulation independently can cause significant dysfunction, leads to lots of issues. Sometimes it can lead to suicide as well, where they will be highly dysregulated, and the risk of suicide will is high. So this is where we are going to look for ASD in adolescent. So these are the clinical cohort and adolescent presenting with these deficits like executive functions and emotional dysregulation. So this is an answer for question, where are we going to look for ASD in adolescent? So assessment. So how are we going to assess? So assessment, if you see types of assessment, so observation based, gold standard is ADOS. It is conducted by clinicians usually. Again, it requires certification usually to give a ADOS report. And parent teacher questionnaires. Okay, so social responsive scale filled out by the caregiver, parent, or educators based on their observation of adolescents' behavior in a daily life. Then self-report questionnaire, surveys completed by the adolescents to assess their own experience and social behaviors. Autism spectrum questionnaire is one example. And structured and semi-structured clinical interviews like 3DI, which is very resource and time intense interview. So what to choose? Okay, it depends on the clinical situation. For example, see this, if you can as a clinician, if you can do observation based assessment, ADOS or sometimes CARS HF, which is easily available and no certification is required, so you can use one of these assessments for the diagnosis of ASD. Observation done by the clinician, but sometimes like when it is not very clear, or it should be supported by the parent or adolescent interview, who's like sometimes the parents will come with concern. Who is coming with concern? The parents will come with the concern for the adolescent. So that time parent or teacher rating questionnaire may be help like SRS. Sometimes many off late we are seeing more adolescents are coming with uh, like I may have ASD, like please help me in getting diagnosed. Especially adolescents who are coming from West, they have very good insight, and like they have very good insight about their social deficits, and they are coming up for help. And in these cases, parent will deny in this situation. They're nothing, like he's normal, nothing, like he's just seeing Google and he's making it up. So here, self-report questionnaire may help to bring the social difficulty they face. So what to use depends on the clinical situation. So social responsive scale is a parent or teacher rated questionnaire that measures social impairment, widely used in both clinical and research setting in assessing communication deficit. A strong correlation with other ASD diagnostics tool, but it may be influenced by the rater bias. Okay, since it lacks direct observation. AQ, Autism Spectrum Quotient. This is freely available in online also. It's a self-report questionnaire designed to measure autistic traits in individuals. If the adolescent has insight, it consists of 50 items to assess social skills, attention switching, and communication. The AQ is validated in adolescent population, but its reliance on self-report raises concerns about accuracy, particularly in individuals with limited self-awareness. So use it when the adolescent has good insight about their problem. Cars. So cars is commonly available. You can use, you can easily make a report. So items, 15 items. So here we are not talking about cars ST, we are talking about cars to high functioning. Okay, so it measures like these domains relating to people. What do we measure here? Quality and appropriateness of cars and ADOs we will see bit in detail before concluding. Okay, so the relationship with people, the quality and appropriateness of the relationship with uh, observation areas include how the adolescent's eye contact is, what are the social interest, how they are initiating interactions, how they are responding to others, so how they are relating to quality of the relationship, and social emotional understanding. Okay, whether they are able to understand emotions, intentions of others, or whether they are able to understand social situations and behave accordingly. Okay, are they, like previously as we told, this tool 0 to 1 to 4, this recognize whether they are recognizing sarcasm, they are understanding social rules, are they predicting good and predicting others emotions. So this will help to gauge social emotional understanding. Emotional expression and regulation, how they are expressing their emotions and how they are regulating their emotions, emotional response. Sometimes flat affect, sometimes inappropriate emotional response like laughing loudly, sometimes intense emotional outbursts. All these things can be observed during interaction. How they are coordinating their physical movements. Okay, that is body use. In this, whether they are clumsy or their coordination is smooth. Is there any unusual motor behavior like stereotypes? Usually in adolescent with high functioning cars, you will not see stereotypes, but you can see this clumsiness and poor coordination between nonverbal skills. Object use, whether they are using object and play appropriately. Usually in high functioning cases, they'll be able to play appropriately. Only in like an adolescent with intellectual disability or autism, low functioning cases, they may have poor object use. In most of the time, they may use. But if you ask history, there may be some repetitive use of objects. Okay, but you will not be able to observe. So cars you can score both with observation and history. Adaptation between, mostly we have to go with the history, like whether they have any restricted interest where they keep doing the same, or like they have very poor adaptation to change. Visual response, two things, whether they have any visual stimming or sometimes how their eye contact is, both will score here. This we can one we can make from our observation like eye contact, and other we have to go with the history. Listening, whether they are listening, whether they are responding, taking time to respond, we are allowing to speak, how they are listening response. Again, any sensory issue will come in this. We have to go with the history, because in your observation you may not get any unusual sensory response, especially in high functioning cars. Unusual anxiety, we have to go with history. Sometimes you may not see during your observation. Verbal communication, like I told, whether what is the quality of spoken language, and whether they are good in turn taking, how they are conversing, whether it is too primitive or sometimes it will too circumstantial, they beat around the bush to converse something. So all these things will come under verbal communication. Non-verbal, gestures, facial expression, body language, eye contact, and its coordination. Thinking, or any rigid thinking pattern that is seen, like too rigid and not able to accept alternative ideas. A lack of abstract thinking. Intelligence, sometimes they will have very uneven cognitive profile. Okay, they may be very good in some areas and like very poor, especially in social communication area. So this discrepancy in intelligence is what we have to observe. And clinicians overall sense of autism presence. So this score cutoff range more than 27.5, like basically taken as autism. Sometimes even score about 25 in high functioning can be taken as minimal symptoms. So the CARS is one of the commonly available high functioning CARS where you can observe as well as collect from the history, and if the score is significant, probably we can make the diagnosis. So this is one of the valid clinical tool. Then next is ADOS. Okay, so what are the ADOS like that is used in adolescent? There are two modules, ADOS 2, module 4. Okay, and module 3. The very small difference between these two, like it is a semi-structured standardized assessment, a gold standard for ASD, designed for verbally fluent adolescent and adults. That is module 4. Okay, and it is more than 16 or more. So 16 years or older, adolescents and adults, and adolescents who are verbally fluent, who can engage in structured social interaction, and high functioning individuals with complex communication abilities. So these are the population where you can use module 4. So this is like 10 to 15 activities. Some activities are optional, and it is conducted through direct observation, taking up to 40 to 60 minutes for a trained psychologist or a clinician. Okay. So here we will briefly go through the list of activities. So what it measures, basically module 4 measures, as well as module 3 measures social communication, social interaction, restricted interest, and repetitive behavior. Like any tool, it measures these areas. We'll go through the list of activity. If I have underlined the activity, like you can use not as a part of EDO. Sometimes when we speak with adolescent, like with the ASD, sometimes you will not know what to do, like because the conversation will not flow. So this is a good tool where you need not construct a report telling like I have done ADOS and the score is this, because you need to be certified to even produce a ADOS report. Here you can use these activities as a part of your routine clinical evaluation. So that the thing I have underlined, you can use in your routine day-to-day clinic. So that gives us lots of information about their social skills. So the construction task, puzzle pieces or laminated design. Purpose is to how the cooperatively they are engaging and how they are responding to challenge. When you challenge them, how they are responding. Telling a story from a book. Okay, this is very commonly you can use. Even you need not, as I said, you need not do it as a part of EDOS. Even otherwise, you can do it as a part of your routine clinical evaluation. Participant narrates picture books without words. So basically, from the picture book, like evaluates how they are narrating, whether they are able to understand what is there in the character's mind, that is the area of mind, ability to infer emotions based on the pictures, and observes. We also observe use of gesture and facial expression while narrating. So telling a story from a picture book rather than words. If you see give with words, they will just read it. So here the picture book narrative will be a good tool to observe social skills. Description of a picture is optional, but we can do it. Describes a complex social scene, ability to how they are interpreting social context. It evaluates understanding of relationship and emotions, and examines quality of the language and description, how they are describing. Again, conversation and reporting. These two things, current work or school, these two things you can use in your routine clinical interview. So natural conversation about daily experiences and activities, including how was the work, and like in case of adults in adolescent school, hobbies, daily routine. Here the assessment is how they are reciprocally communicating, and whether they are involving in conversation. Okay. And current work or school, again, evaluates ability to report routine and non-routine events, and description of social relationship, whether they are only too concrete. Okay, I'll go to school, I'll study, I'll come back. Whether it is too concrete, or they are able to, met my friend, like we were able to discuss these things, whether they are descriptive about social relationship. This will help in a routine clinical interview. Social difficulties and annoyance. Awareness about whether participant awareness about social challenges. We can discuss about situations that can cause frustration. We can assess insight into their own difficulties. Okay, and evaluates emotional understanding and expression. So we can do it by gradually discussing about these social difficulty and annoyance, if any, in their routine life. Emotions. Various emotional experience the adolescent undergo and the triggers. And observations, we have to observe facial expression and insight about their emotional difficulty. And again, it is through conversation and discussion. And ask them to demonstrate some routine activity or a skill. Okay, demonstrate how you dance, demonstrate how you tight a screw. Okay, for example. Okay, additional language sample, you can get additional language sample about their verbal ability to adapt to the narratives or to the listener. Observes use of gestures and how the coordination is. So these demonstrations and talking about emotional experience can help us to understand their emotional insight, as well as how they are demonstrating and using their gestures to explain us. Cartoons. Participant, it's optional in edos. Participant explains humorous cartoon or comic strips. Understanding of humor and social nuances. Evaluates ability to interpret implied meaning and observes response to humor and playfulness. Whether, see here, many, if you like, somebody wants to get well versed in edos, one thing is like we have to do these activities in the neurotypical adolescents. So then you will have a clear, or like if we do 2 4 or 5 neurotypical adolescents, like go through this task, you will be able to see like how they are describing. And when you get adolescents with ASD, you will be able to clearly see the difference. If you don't do this activity with the neurotypical adolescent, very difficult to know whether it's normal or abnormal. Okay, because all these things are very subtle signs. There is no discrete scoring, where many a times you have to go with your subjective rating. Daily living. Discussion about self-care and independent living skills. Explores daily living and responsibility like a discussion. It evaluates adaptive functioning level. It is an indirect indicator of a SQ. Explores understanding of friendship and relationship. We can ask them about how he interacts with friends, how he manages relationship, and if it is adult, it's marriage. We can assess insight into their social relationship, evaluate the quality of the social reciprocity. And going higher, we can discuss about loneliness, assessment about emotional awareness about their loneliness. And creating a story creates a narrative using provided objects. Okay, this we cannot use in a routine clinical thing. It's part of edos. Here the 6 objects with clear purpose and 6 ambiguous objects. Here we'll see how they are using ambiguous objects. Okay, whether they are creative and there is a narrative coherence. So what overall with these exercises in EDOS 4 module, or sometimes module 3, the assessors observe the eye contact and facial expression during interaction, quality and reciprocity of the conversation, use of gestures and body language, and ability to share that whether connect is there and whether they are interested. So overall with this, we will be able to conclude whether they have social communication difficulty or a very rigid repetitive pattern with a poor cognitive flexibility. So module 3, it's almost similar. If you see the item, not going to go into items. If you see, it's almost similar, but like it is more play based, and the module 4 is more discussion based. So module 4, like we talk like more less play and more discussion. In module 3, it is less younger than 16. If you see 12 or 11 or 12-year-old, like it will be more play based. Okay, so it's almost otherwise similar items and tools. So with this, we'll again revisit this content. Why diagnosis missed early? Because of that in some cases trajectory, they lose the diagnosis, but diagnosis doesn't go off. They no longer meet the criteria. Sometimes misdiagnosis. This is why we miss early and getting diagnosed. what signs and symptoms we have seen, where cohort of patients presenting with psychological problems and subtle deficits like executive functions or emotional dysregulation, and what clinical judgment is the best way to diagnose ASD in adolescents, and tools are supportive. Commonly, we can use two tools. CARS HF, it is commonly available. ADOS module 3 and 4 if you are certified. Otherwise, if you are not certified, you can use some of these items from the tool that gives you very good piece of information, especially when you have gone through this way of interview with the neurotypical adolescents. Thank you.
Thank you so much, Dr. Venkateswaran, because I think you made it very simple and easily palatable because it's a very, very difficult topic to touch upon. Many times we miss out, we just like tend to say that like ASD traits, or like sometimes if they just like overgrow, then they will just like be put into the schizotypal or personality, evolving personality kind of. Or some people just they miss out because like there will be a overshadowing with social anxiety disorder. So you just brought up the right point of actually where to find out these people is because many times when we have a psychiatric diagnosis, I think the ASD population like they present differently. And like as you said, like probably gender dysphoria, eating disorder, these are all population where we don't actually get to look out for the atypical presentations of like ASD in the background, which is actually masking the picture. So thank you so much. And more importantly, I think you elaborated more on how to actually clinically evaluate wherever possible with simple things like actually asking them to narrate a story or like narrate their experiences. So these are all certain things that will actually help as a clinician. So one thing that I just found very interesting is also the varying sexual behaviors like that can actually present in adolescence. So many times, like they may be just mistaken for any even perversions. So like sometimes like exhibitionism or like people are like adolescent actually looking at a female without knowing how to actually express their romantic gestures like constantly. So they may be mistaken for even stalking. So, like, this is another area which is very untouched, but I found a very interesting article and research in autism called, it's like, I'll share it in the group, effective sexual education intervention for these adolescents exclusively, because many times parents comes to us as they do not know how to actually handle these public masturbations in adolescents and all those things. So this is one area where people come to know about like they do not know how to actually uh, uh, display their romantic expression. So that is one area where we also actually tend to identify this population in the adolescent population. Is just one thing I just thought like based on what I have actually read. So I would request participants if you have any questions or queries, please do actually unmute yourself and ask. Uh, Somebody has asked what is the cost of ADOS tool modules and how can we get it?
No, but IDOs require a certification as far as I know. Like if you are giving a formal report, you have to go through that certification training. In CMC, we do ADOS part of our training, but like, are we authorized to give official ADOS report again? Like, we are not supposed to.
I think this clarity of information on this ADOS 3 and 4 is, I think, very useful because many times, like, we are used to actually using for only children. But I think it is a very exhaustive module for like adolescent and adult population where we'll have some evidence to say that, like, even to provide to the parents or provide to the clinicians that, like, to certify somebody with autism spectrum disorder. So somebody had asked, but I think I couldn't see in the chat box. So the reason for non-persistence of ASD symptoms, I think when you just talked about the first article, I think Dr. Nisha Mariam George, I think she had posted a query on that, like the reason for non-persistence.
So it is, they have given two factors, sir. Like one is like female gender, sometimes the symptom they sometimes outgrow, and more of these females are later on go on to get diagnosed as personality disorder, because they will develop communication, they will develop social skills, they will be able to socially behave appropriate. But in adolescent age, they will develop very intense emotional dysregulation, where they will go on to diagnose as one of these personality disorders. But if we actually see this spectrum, many of these symptoms they improve, and they will have, but reason very non-specific. We have to take it as a part of trajectory of that particular developmental disorder, like how different illness have that. See, it is not hypertension also. If you take, it is not that every hypertension goes in the same trajectory. One will go on to become severe hypertension, accelerated hypertension, some may end up with cardiac disease. Some hypertension, they will stay as mild hypertension for lifelong without doing any harm. So any illness, the trajectory is variable. ASD also trajectory is variable, but two factors: one is female gender, second is if the baseline adaptive behavior, not IQ, they are very specific. If the it is not about cognitive intelligence, if the baseline adaptive behavior as measured by VAPS is high, then these are the children like have slightly better prognosis, and they have a higher chance of not having. It is not that the diagnosis is going up, it is not that they no longer meet the criteria for the diagnosis. That is how, it is not that they are coming out of spectrum. At some point they will have different challenges, so they no longer meet the criteria for the DSM-5 or ICD diagnosis of ASD.
Okay, sure. If there are any other queries for the speaker, like people can unmute yourself or actually post in the chat box.
Yes, sir. This is Dr. Kannan.
Yes, sir. Please.
Venkatesh. Good evening, Raman. Good evening, Venkatesh.
So good evening, sir.
Yes, you had been talking about ADOS. Can we make a simple scale copied from that based on that principle? Because in US, what is the culture is they subtly alter one or two items, they rename it on their own, and finally they put a price list of $26, $30. Why not we make our own scale? Let that be yet to be validated or partially validated, or the scale may have some limitations. Why should not we make a scale, rough scale? Let the people comment on it for its negatives. But why should not we? Because in the second edition, we can correct those things. If you do it alone, or if I do it alone, it will not be accepted. But as we form an expert committee, and three people were continuously working in autism or child and adolescent psychiatry, if they come up with a scale that is adopted by Tamil Nadu Psychiatric Society, probably that would be the beginning for developing some skills. This is my opinion, and we are over relying on psychologists and other things. Psychologists, yes, of course, we need their support, but over relying also need to be avoided. These are all my just inputs to it. Dr. Raman, what's your take on this? You are having a responsibility in an institute, academic institute.
Sure. So I think if the speaker has any comment on the ADOS validation or like modification
So
of the tool.
we can take inputs from all these scales and we can develop one of our own. That is a good idea. It need not to be ADOS. We can take inputs from other scales. This is how usually the rating scales are developed. It is not that they are creating something new. If you see ADOS and CARS HF, there are so many overlap. So like that, we can like to make it more our culture specific. So that is a good idea, but again, like it is very resource intense and time intense. And as sir said, like few people involving, we can try that, sir. Like
Yes, sir, definitely, sir, because it requires a lot of effort to be actually put in. So definitely we will work on forming an expert committee to just work on this also, sir, as suggested. Definitely we will.
Dr. Raman,
Sir.
currently what we are doing is a clinical IQ assessment we are able to do. We are training our PGs to some extent. They are not completely in blank. They know something to assess about IQ. Clinical IQ assessment is also part of NMC requirement. So similarly, we can train them to some extent rather than simply referring the children or adolescents for assessment, they should have some idea, then refer them to psychologist. Then we will have a validation so that their assessment can be validated by their. Sometimes psychologist reports are, well, unpalatable.
Sir, I just will go with what you said, sir. Actually, I believe in this concept of this self-sufficiency. A psychiatrist should be knowing when to refer and for what purpose should be refer. Even if the psychologist provides a report, like a psychiatrist should be able to read the report and probably he's the clinician, primary clinician, who has to actually take what is the information provided by that report and not just by the report just sent to the psychologist just for the sake of sending. So this concept, I'm personally, if you ask me, I'm very, very clear about it. And I also believe that like as part of the training, I think we should equip our postgraduates to actually make some meaningful inference based on simple tools or from clinical judgment. So just for diagnosis purpose, I think we have also stopped off late. Like the previously, we used to send people for Rorschach for unidentified actually or ambiguous situations for whenever there is a suspicion about psychosis or we are not. Now our clinical judgment has become much more better, and we have not been using Rorschach and like very rare like we have just not been using. Just Rorschach is just for like only for maybe the training, okay, there is Rorschach cards is available, link blot card is available. So similar situation will also come in child psychiatry where like we will be relying more on clinical judgment rather than relying exclusively on psychologists. I think we should also train our postgraduates in a way that like they should be able to manage even at a postgraduate, after postgraduate level, to actually manage some conditions like ADHD, autism, because the developmental pediatricians on one end and like the pediatric postgraduate trainees are also developing interest in like this developmental disorders. So I think we need to actually equip our postgraduates to actually dwell more into this developmental neurodevelopmental disorders and take up child and adolescent psychiatry, not just do fellowship or not those do DM and then master it. Rather, it should be integrated as part of the postgraduate training because I think we should just move to that level is my own personal thought process.
True, true. But when somebody is excessively interested, then there should be some way, no? For
Yes.
that, at least there should be fellowship. But
Yes.
I think that our president would be very happy if we form a committee and start developing these kind of tools. Let there be some mistakes or drawbacks. Huh? Let us
Sure,
go
sir.
for some developing such skills. If you are planning something, please include me in that group so that I can
Definitely.
also put some in. I can give some inputs.
Sure, sir.
Thank you.
Sure, sir.
Thank
Thank you
you.
so much.
It was a good presentation, Dr. Venkatesh. It was
Thank you,
very
sir.
elaborate and very comprehensive. Thank you.
Thank you,
Thank
sir.
you so much. If there aren't any other questions and from the forum, I would take this opportunity to thank Dr. Venkateswaran for taking his time out and presenting on this like interesting topic because definitely this is it's recorded, so we'll definitely will be sharing the recording to all the people who are unable to actually make it. And thank you for all the participants who actually joined and out of your busy schedule. And we look forward to another webinar series for the next month. It's happening on every third Saturday. And sincerely thank Tamil Nadu Chapter IPS President sir, and all the EC members for this opportunity. And thank you once again.
Thank you, sir.